So that's my daily use of the laser. So if we're going to do the exposure of the implants, I like to use for some of them, it's almost like a tissue punch, where if I have a good band of keratinized gingiva, for instance, anteriorly in the maxilla or even posterior in the maxilla, I find that I can just put the settings on, as you see. These happen to be the settings I use. I use a 6 or a 9 millimeter tip. But it's a very simple thing to do. You just take the laser and I use a little local anesthetic. That's just my nature. I just haven't had the inclination to do it without that. And then I very carefully remove a circle of tissue, exposing the implant. I really don't care if I get close to the implant because the setting is such a cold laser. So then I remove the soft tissue. There's very little bleeding. And then I remove the cover screw and place the abutment. It's very simple. If I need to elevate the tissue from the site when I do the exposure, I can just turn the laser on an angle and almost elevate a flap from within without making a vertical incision. So it's quite nice. If I have a thin band of keratinized gingiva, for instance, posterior mandible, then I use the same settings as above, and I take the laser and I just go right through the keratinized gingiva to bisect it. So I preserve it, and then I make vertical releasing incisions with it, and I angle the laser tip and actually reflect the tissue right away off of it. Very simple. I then use a perioperative elevator to reveal the implant. I clean the surface with the soft tissue with the laser. Now, removing the bone that's overgrowing some of these implants, I may use a scalpel blade to do that, or I may use the laser. It just depends on how thick the bone is. It's just a matter of preference at that point. But it's very simple to use. Very little bleeding, which is nice for the patient. The nice thing about all of this is it's relatively bloodless, and patients do well. So here is a video of just exposing a healing abutment that was placed, which was completely covered up. So this is a patient who we want to preserve as much of the tissue as we can. So I'm very gently removing the tissue with the laser, as you can see. Very easy to sculpt it. The restorative dentist then took the impression on this patient the same day. The patient had very little bleeding, very little discomfort afterwards. Even when I'm taking an excessive amount of tissue off, say in the posterior maxilla on a redo patient, I find it very simple to use the laser. So that's how simple it is. It's very, very simple to use. It's much easier than a scalpel blade. Sometimes if the implant healing abutment is straight without a flare, I do a lot of straight healing abutments if I use a relatively small flap, or if I don't want to push the envelope on the tissue healing when I place the implant. I use a straight emergence healing abutment. But I want to change it to a flared one, and sometimes with some of the internal connection implants and a two-piece healing abutment, it's not that easy to seat those, so I find that the flared abutment may not easily fit. So what I do as a solution to this, I use the laser to recontour the sulcus, and I'm literally sculpting a flare then. What I'm thinking I like about the laser is when I use that and sculpt it, I'm also elevating the tissue slightly from the actual base of the implant. So when I place the flare healing abutment, it just snaps right in place. And I also use the same method if I need to change the abutment to a taller one, if the abutment itself, for instance, is used for the impression. And there are some systems where the healing abutment itself has a score, which is then used by a computer to create a custom-made abutment for the patient. So some of those you have to adjust by placing a taller abutment. And if I need to do any soft tissue work, the laser doesn't delay anything. So this is a case where I've had a 3 millimeter tall abutment in place. It was not flared. It's a two-piece abutment, and I need to place a taller one. So I initially sculpt the area just to re-expose it with the laser. You see it's very atraumatic. I do have a little local anesthesia in the patient. And I unscrew the center screw of the healing abutment, it's a two-piece, and lift it straight out. Well, I lift it straight out, and then I test these. I place the radio frequency tool in there, and I ping it, so now I get a good big ping. But you see right away the flared abutment doesn't fit. So I then take the laser and sit right there on my operatory, and I pick it up, and then I sculpt the area. A little bit of water, of course, is flowing out. That's how the laser works. So you need to have some suction. And we suction the area, and I just create a sculpted area, and then I placed the flared abutment, which was too short, so then I went with a taller one. And you can see how easy that just snaps in place. Very little problem with tissue. So it's a very easy way to go to change the healing abutment out. I like this technique tremendously. It makes it very quick for me. And very little bleeding. So for that, the patient likes that. Now, some of you are doing computer-guided surgery, and I find that the laser is useful in that regard as well, because when you use a guide for surgery, you normally use a tissue punch type drill, which removes a circular piece of gingiva, does a gingivectomy. But the bone ridge in my patients is very rarely flat, so the tissue punch gingivectomy is not complete. There's a little typo there. It should be not complete. And in that case, I find if I remove the tissue at that point, I'm tearing some tissue. So what I do is I do the tissue punch with the drill, and then I take the laser and complete the soft tissue gingivectomy, which I also find decreases bleeding. This is for guided surgery, and it's very important, I believe, to remove that gingiva completely and not remove it by the drilling sequence. So I like using the laser. So let me show you two cases like that. And so this is a patient on the mandible, and I'm put the stent in place, and before I fix it with screws, I just take the tissue punch drill, and I'm going to remove or make the scores, but this ridge is not flat at all, not even close. So you'll see I'm making the first cut with the tissue punch, and then I continue with the tissue punch even to score it. Now I take the laser, and I go right around the circles. Now I'm going all the way right down the bone with the laser, and I'm using my normal settings for it. I don't get too involved with the different settings. I don't find that I don't need too many settings to do what I do. And then once I complete that, you see how easy the rongeur just takes the plugs out. Also notice very little bleeding. So these patients, when I'm done with surgery, they don't have much swelling and very little ecchymosis. So I'll show you a maxilla, same way. So now in the maxilla, I've already done the tissue punch. I've removed the guide stent, and now I'm taking the laser and going right around the sides, as you can see there. I just go right around, and that completes the gingivectomy. Sometimes the tissue just falls out when you do that. If I need to, I can stop the laser and feel the bone. So I do this routinely. It doesn't take me long to do this. You see, there's a little bit of bleeding there from the tissue punch, and you get some cauterization with the laser, not excessive amount on this particular mode, the hard tissue mode, not a soft tissue mode. I don't want to burn the bone, so I'm very careful. But you can already see the decrease in bleeding on the sites when you do that. And then I just take the rongeurs, I use small ones, and I just take those plugs of tissue out, and they lift right out, and then I'm ready to put the stent in and do the guided surgery, which I didn't have on the video since it wasn't part of this presentation. Now, the other part that I like is a procedure that I saw by Dr. Dyer, and just to give you a little background on this, you've all probably, if you're doing sinus elevations, and I'm assuming most of you are interested in this because you're attending, then the traditional summer type technique where you create in a 7 millimeter vertical bone, create a hole that's 5 millimeters deep, at least 2 millimeters of bone on the floor of the sinus that needs to be elevated superiorly. Now, some people will take the osteotomes and immediately raise the floor, and some people put a graft in there to act like a little pad and then use the osteotomes to elevate the bony floor with the membrane. And when I've done that in the past, I've had mixed results. Some look great and some look less than great. And when I'm talking to my peers, they agree. So what Dr. Dyer showed me was to use the laser to score the peripheral part of the inner core, just like you were scoring glass if you're going to cut glass or cut slate, do any kind of hard ceramic cutting. You make a score line and then crack it on the score line. So that's the same thing we're doing here. So I find that I do this now routinely, and it doesn't even stop me. It doesn't add more than 5 minutes on the procedure, and I'm able to place implants routinely in this bone without doing a lateral wall infracture. So, for instance, the patient has 7 millimeters of bone, and I want to place a 10 or 11.5, 12 millimeter tall implant. Depending on the anatomy of the adjacent sites, I'll choose a 10 or 11.5. Now, I need to move the sinus floor superiorly, and as what I do is I prepare the implant site to within 2 millimeters of the floor. Now, if you're doing guided surgery, you can plan your guide stent so that the drill will actually go to that depth, which is a very slick way of doing things if you're doing guided surgery. Or you can measure it. I use a cone beam CT scanner to do that, so I have a very accurate measure. And I tend to, if anything, shy a little bit thicker than thin. So I'm going to try to be within 2 millimeters. I use the laser to score the periphery of the inner wall. And again, Dr. Dyer showed me this, so I'm not the inventor of this. He was very elegant when he showed it to me and very kind to show it to me. Now I place the graft. I happen to use a lot of allograft here or autogenous bone. You can use xenograft. It doesn't make any difference as far as I know. And then I use flat osteotomes to elevate the floor. And I would get the osteotomes that match your implant site. So if you're using a tapered site, you get the tapered osteotomes that are appropriate. Go ahead and spend the money for them. Then I finish the implant site carefully and then place the implant and the graft. So I'm going to show you a couple cases on that. So this patient is somebody who comes in. I've already done implants on her posteriorly about 20 years ago. Those cylindrical implants are doing actually quite well. But she comes in for the upper left quadrant. So in the maxilla, you see she's got a second molar that needs to be removed. And these are the kind of cases when I remove those teeth and graft them, I end up with 7 or 8 millimeters of bone, and she's got opposing fixed dentition, so we want to put something solid up there. So what I'm going to show you here, the image on the left is a cross-section from the cone beam. The image on the right is the implant with the bone moved superiorly. And you can see, if you look carefully, that flat sort of radiopaque line, which is the floor of the sinus, moves superiorly. These cases, you can just do all day long. And it's a laser. I really do believe that when I'm using a laser, my results are so predictable with it. It's I don't know what I would do ethically not to use it. I hate to say that, but it's true. It works very, very often. Well, now when I'm let's see if I can advance. There we go. So now you can see on this case that the implant in the first molar was just placed routinely. But the implant in the posterior site, you can see was elevated. You can see the elevation on the floor. It was quite good. So let me show you the video of this particular case. So now I'm in here and I'm drilling my hole. I do a flap on this because I can see the bone, although I probably didn't need to. I'm preparing the site to about 6 or 7 millimeters. I take the osteotome and just make sure it's wide enough for the implant, and then I take the laser now. And I'm going to use a longer tip now. There's several length tips. Use the longer tip on this. So, and I actually, before I started, I palpate the floor and get a good idea where the floor is, and then I go peripherally around it. And I'm using a 20-30 air water. That's what I use, about 2.5, 3 watts at the most. And then my pulse rate's about 30 when I do this. And then I take a little bone from the tuberosity if I'm there, or take bone from the drills, and I place it in position. And then I use the osteotome to tap the floor up. This is the case I just showed you, so you're seeing it. And I tap it. A little bit of tapping there. I may be a little less aggressive on I sometimes leave a little thicker bone. So I tell the patient there's going to be a little tap. And I very gently tap the floor up to my third line on this particular osteotome, which is 11.5 millimeters. And then I take it out, and then I place the implant. That's the way this one works. And this patient's restored and doing great. Good bone formation over the last 2 to 3 years. So once I get this in place, I actually didn't have the wide platform driver. It was in another kit, so that's why you saw that. So that's a case that worked out fine. And then I'll show you another case. This is an interesting case because in this case I'm going to do 2 things with the laser. And if I have the laser that I'm using for one application, I typically use it for another one, the same patient. So this patient comes in and she's got a full set of teeth, but on the left quadrant she's got double abutted premolars with a ponic to a second molar, which is symptomatic. And what happened on her, if you look at the periapical on the right side of your screen, you see there's a fracture in the second premolar. It turned out the first premolar also had a fracture, which was hard to tell, but when everything was cut off, it broke at the crown. So that tooth needed to be removed later on. The second molar with the root canal has been retreated 3 times and is still symptomatic, so it's tuned in to be removed. So our game plan here is the first session was to take the fractured premolar out and do 2 implants. So you can see the site here. If you look at the cross section, you see I've got 8.8 millimeters of bone. Now I could place an 8.5 millimeter implant, but I wanted to place an 11 on her to give her a little more height. So that's what I ended up doing. And so in the surgery, what I'm doing here is I'm using the laser to now make a trough between the tooth and the bone. So I typically increase my wattage a little bit and decrease the pulse rate and almost make little plunges, little small holes in the gap in the periodontal ligament space. And then once I do that, I find that the air and water makes it very easy to take out the tooth. This was a fractured premolar, which came out, very simple. It's ridiculous to see how simple these are. Now then, in the preparation, I've cut out a couple of steps here just for timing, but you'll see there I'm preparing the molar site to about 7 millimeters. This is a 8 millimeter drill posteriorly, and I'm prepping the anterior site like I normally would. So I've got the prep, and I'm taking the bone from the drills, these taper drills. So here you see it's an 8 millimeter drill, and I'm taking it not quite to depth. Now here's the laser. Now what I'm going to do with this laser is I'm going to take it and I'm going to place it into the preparation site and just go peripherally around the core, so the floor is being scored. And I go real slow, and I go around that hole maybe about 3 or 4 times, and that's about it. I don't want to perforate the bone if I can. I just want to score it. So I do this score, and I'll stop it every now and then and feel it. You see I go in a circle. Then I put some graft material in the spot, in the hole. That's the graft material.